Okie dokie, we are live, and yeah, everything seems to be going fine. Okay, welcome. Good evening, everyone. Apologies for a slightly delayed start. We had some technical issues, but we're all here. That's the main thing, and we're going to bring a really informative event tonight. We're here to talk about varicoceles, and I literally couldn't think of a better person to have on to help us talk about this and cover the really important topic, because pretty much every bloke I ever speak to, when we talk about varicoceles, the following name that comes is yours. Dr. Steven Moser, welcome, and thanks for joining us this evening.
Delighted to be able to finally. The delay was all mine, I'm afraid, everyone. So my apologies.
Oh, thank you. I wasn't going to throw you under the bus. Thank you. It's okay. We're here now. That's the main thing. So yeah, we're just what we're going to do this evening is just cover anyone. This is for any men who are undergoing fertility investigations or who have been told they've got a varicocele. So we're just going to cover what they are, how to know if you have one, how they can impact male fertility, and what treatment options are available. Really. So before we start getting into that, before we do, I always start with a disclaimer, and that is that Nexus events are designed to provide objective oversight, balanced information, and general guidance. Nothing shared during these sessions is intended to replace personalized medical advice. Always consult your own healthcare provider with any questions or concerns about your health, fertility treatment, or changes in your condition. So yeah, like I said, we're here tonight with literally such a prominent name in the world of fertility, especially when it comes to varicoceles. So Dr. Steven Moser, welcome again. And I just wondered if you could give us a quick introduction of who you are and what you do.
Sure. So my name's Steven Moser. I was initially trained as a doctor. I did many years of cardiology, and then I did radiology, which is all things imaging, X-ray, CT, MRI, all of that. Then I did a specialist fellowship in radiology operations. That's called interventional radiology. And for the last 20 years, I have been doing a combination of X-ray work, which is all things radiology, and also operations, which is interventional radiology.
Amazing. Thank you very much. So yeah, I'll start at the top really. Before I go in my first question, I'll just let everyone know that I've just opened up the Q&A function. And as always, you can ask anonymously, which is a really important factor that we bring here at Nexus, because we get it. We understand where some men can be at certain times. So yeah, starting at the top really, Steven, is what is a varicocele and how does it form?
So, not wishing to sound sexist, if you look at your granny or your auntie's legs, they're more common, I would say, in women than men. Often they have enlarged veins. That is a varicose vein. Now, they can occur all over the body. One of the places that they can occur, and again, not wishing to sound sexist, but only men get these. You can get them around your testicles. That is a varicocele. It is dilated veins that occur around the testicles. Now, 9 times out of 10, they are on the left side, and 1 time out of 10, they're on the right or on both sides. The reason that they occur more on the left is just because of a slightly different way that the vein drains on the left compared to on the right. And that presents itself as thickening lumpiness around whichever testicle is involved. And you can get pain, often a throbbing, low-grade, achy type pain. And that tends to occur usually after activity, exertion, sports, for instance, or after you've played football or been working out at the gym. And also it's worse the hotter it is. Why? Veins dilate up when it's warm, and those veins are no exception. And one of the things that happens then with this is, because it's these veins dilate up and heat in the heat, because they are dilated, they act almost as a sump, like the radiator in the corner of the room, and they heat the testicle, and that heat can cause problems with the testicle directly and also with its function.
Okay, thank you. I do remember my dear Nan's varicose veins in her legs very well. But yeah, it's quite an image to think that that could. Well, it does happen. You know, I had a varicocele. Kieran, my co-host, who's here this evening, co-founder, he had one as well. So in men, how common are varicoceles?
15 to 20% of us will have them. The taller you are, the more likely, but that doesn't mean every tall person has them. I'm only 5'2". I haven't got a varicocele, but I spend most of my time on my feet. Anybody can get them. Because they are so common, we don't actually know what causes them for certain individuals, but by and large, increased activity, height, and heat are things that cause them. Now, a varicocele per se is not dangerous. It is not a sign of, it's not going to progress to cancer, but sometimes varicoceles can be a warning that there is something happening downstream, and so the blood isn't draining as well. So whenever I check for a varicocele, one of the things I check for is whether or not there is a problem that is coming downstream, so that the vein is blocked for various reasons.
Hmm. And
But one
in
in five.
sorry, Stephen, go on.
No, I just said, but 1 in 5. You asked
Okay.
about.
Yeah, so that's men in general. How about subfertile men? Are varicoceles something that you see that are more prevalent in men that suffer with their fertility?
So here's a really interesting little fact. Men in a within an infertile couple where there has been found to be a female related problem, the incidence of varicoceles in the man who is supposedly not contributing is 1 in 3. So it immediately raises the possibility that even where everything seems okay in infertile couples, 1 in 3 compared to 1 in 5 to 1 in 6 in the general population.
Wow.
So
Wow, that's yeah, those stats certainly then creep up, don't they? So for
and
anyone
even higher when the man presents himself as the primary, wondering if he's the cause of infertility, because by and large, in the way everything is set up, everything is geared towards sorting out female infertility. The assumption after a very cursory assessment of sperm is that, yeah, that's not the problem. And so many couples go through the trauma of cycles of IVF or various other attempts at getting pregnant. And having optimized everything with the female, often the male is not optimized. And pregnancies can occur and then they just don't carry to term. And this is the big problem, which you haven't asked me directly, but which I'll come to now. That heat, any heat, any abnormal heat can damage protein. DNA is a protein. It's a very valuable protein. And as the temperature rises, with that sump effect and the heating effect of the varicocele, as the temperature rises, you get damage to the DNA. Now, damaged DNA equals damaged growth of the embryo. Now, the embryo can go through the whole of the pregnancy, and it could have been a trivial DNA which didn't affect it. It could have been a very a life developing DNA, and therefore the pregnancy is lost at the point where that DNA is required. Or it could be a segment of DNA which is required for certain normal developments, and then you could have a live born child which has some kind of a reduction to their function, be it physical, mental, or otherwise.
wow. So yeah, I mean that shows the importance of addressing varicoceles if possible. In terms of diagnosing them, is it something that patients can figure out if they have them themselves, or maybe in some, not if not all occasions, or does it have to take a healthcare professional to identify a varicocele?
Every man should know what's in their ball sack. It's what we do. We fidget.
Yeah.
If you don't have a nice smooth testicle with a little bit of thickening behind it or to the side of it, and there are lumpy, bumpy bits around the testicle, it could well represent a varicocele. That's the first step. If you get pain on exertion, so this is a real problem because it's not a specific pain. It's not just ball ache. It could be aching around your back, going down to your groin. So many men present thinking they've got a groin hernia, an inguinal hernia. Or it could be pain around the belly button and they just think, oh, this is a stitch. I'm just not as fit as I used to be. So it's difficult. But if you have any of those symptoms, I suppose the next thing to do is to be seen by your health professional and to then have an ultrasound, and that is diagnostic. So in a professional andrologist's examination, they will almost certainly spot a varicocele, and there are many excellent colleagues that I work with. There's Jonathan Ramsey, there's Ted Yap, there's Suks Minhas, many. I'm just naming three, not because I'm publicizing them, but if you look for one, you'll find 100. Many of them, when they examine you, they will be able to tell you straight away that you have a varicocele. It is very rare when I get referred a patient for an ultrasound from one of these, from one of this number of andrologists, that they were wrong. They're just using the ultrasound for confirmation. But if your GP is referring you, I think it's wise to have an ultrasound.
Yeah.
And that's
So
that will confirm it.
sure. What if a patient is going to their GP because, as you said, men should know their balls, and we should be doing those checks. What if a bloke finds a lump, thinks that that's not something he's felt before, goes to the GP, the ultrasound occurs locally, and not an andrologist kind of examining? Can that happen, or can
That's
people?
all right. Part of an ultrasound should be checking that the testicle is normal. There's normal blood flow. There's no tumors in it. It's checking that the epididymis, which is, if you like, the storage sac for sperm once it has developed within the testicle, if that is normal. It is then checking if there is fluid around the testicle, which can be a sign of inflammation. That's called a hydrocele. It's checking then if there are abnormal veins, and that's called a varicocele. Those are pretty much the four things that you look for. I mean, there are nuances, little bits and pieces, but pretty much every trained sonographer or doctor who does ultrasound will be looking for those things. Now, most are quite dismissive of varicoceles. I have noticed. So they'll say, yeah, there is a varicocele. Are you having pain? No, not really. Or yes, maybe a little bit. Oh, well, it's probably not serious. And it's often dismissed. And then as time goes, you find that while it may not be a primary problem, it is causing issues such as infertility or hypogonadism. So it can, that the heat and the varicocele, which doesn't allow blood to flow out so well, means blood doesn't flow in as well as it could. So that back pressure can then reduce nourishment of within the testicles. So your testosterone levels can fall, and you can get some shrinkage called atrophy of that testicle. So there are quite potentially profound consequences.
Wow. Yeah, exactly. And that's, I think, the importance of being checked, and being checked thoroughly and properly by the right professionals. So you've mentioned before that the varicoceles and the the extra heat that they can have, the causational effect of that on the testicles and the DNA of the sperm. You mentioned the fact that it can potentially impact sperm production and the size of the testicle. Is that in relation to fertility? Is there anything else that varicoceles have a direct impact on?
Testosterone. So
Well, just
that is often very few people actually have their testosterone levels checked, but a low testosterone is so far-reaching in its effects. It's not just about, you know, big macho men. It's about drive. It's even about libido. You can have erectile problems. You can, you know, just not have any sex drive, and you can just have no drive at all. It's almost like having an underactive thyroid, for those who know about that. Again, another common condition, which incidentally can also contribute to infertility, but that's a story for another day. But yes, the reduction in testosterone has far-reaching effects, and those aren't mechanical. Those are widespread endocrine, and that can contribute. So it becomes a vicious cycle. The reduction in testosterone can then make the testicles shrink even further, and it becomes a vicious circle.
Yeah, definitely. So you've mentioned the kind of process that someone might go through to be diagnosed, and especially, like, it'd be great if people then found themselves in front of an andrologist who really knows what they're looking for and looking at. What happens next? Are all varicoceles treated, or are some kind of left because they might not be hitting a certain criteria of size, for example?
So I don't treat a varicocele because I find one. The three reasons that I would treat a varicocele are if it causes pain, if that swelling is something that is troubling the individual, and if it is contributing to infertility. Otherwise, you know, we're going to be treating 15-20% of the male population. Most men who have varicoceles live a normal, pain-free life, and a life where they are more than able to have children. So I don't fix something based on the imaging. I fix it based on one of those three factors, and often there are more than one.
Yeah.
And the fourth, of course, is the testosterone, but that is rarely checked.
Yeah, sure.
So I had a teenager just a few weeks ago, and during development, of course, if you've got a varicocele, the risk of atrophy is much higher because you're going through puberty, etc. And imagine if your testosterone levels are being affected, and you've got this varicocele, which is painful, so you're not playing as much sport. And of course, the heat and the low testosterone is affecting the size of your testicle, and it could shrink. So for me, that is an urgent. It's not obviously an emergency, but it's an urgent situation. But for the rest of us, if there's a problem, it needs to be dealt with. Now, in infertility, if the parameters, so the DNA fragmentation, the other sperm parameters, are completely normal, then one might argue, is the varicocele directly contributing to infertility, i.e., is the male even infertile? That may be a situation where a varicocele is present, but it's not the male at all that's contributing to the infertility. And the DNA fragmentation would again be a very useful test here.
Sure. One of the things that we're really passionate about here at Nexus is cutting out kind of misinformation. And online, one of the things I often see written about varicoceles is about grading. So how and when does grading happen, and is there a certain trigger point where that might be acted upon? I assume that's probably going to also tie in with, like you said, the four things that it could be affecting anyway.
So the grading has been something that was set up long before ultrasound. And it is pretty much about the examination. So going from nothing, which is zero, to a very mild one, which doesn't reflux, and so on and so forth, till a great big varicocele, and there are numbers associated with that, the size and also the degree of reflux. Now, with the benefit of ultrasound, you can see with a patient lying down, the people will often scan a patient lying as well as standing, but I'll come back to that. When you're scanning, what you're really looking for is veins that measure less than 2 to 2.5 millimeters. Now, at 2 millimeters with no reflux, that is normal. Now, what do I mean by reflux? When you increase abdominal pressure, so for instance, if you cough, if you laugh, or when you strain, like when you're doing a wee or emptying your bowel or whatever, lifting a heavy box, that raised abdominal pressure, if that vein is defective, and I'll come back to that, it pushes blood in the wrong direction, and that is called reflux. Now, what does defective mean? All of us have veins. Veins take the blood back from wherever, be it your legs, your arms, towards the heart. So if the vein is defective, what I'm essentially saying is it's either a large vein or the valves which make the blood flow in the correct direction are defective. It's usually the latter, and because of that, the blood, instead of flowing in the correct direction out of the testicle, is pushing backwards, and that makes the veins dilate up. So it's usually the case that the valves are defective, and that's in the chicken and egg situation, the valves being defective came first, and then the veins dilate up. And that's essentially the problem. And once that happens, it just perpetuates. So coming back to your question, if a vein is dilated, but I can demonstrate no reflux, so I get you to cough or to strain, to tense your abdominal muscles, and I show no reflux. If it's up to 2.5 millimeters and there's no reflux, I would not pin down that as being a significant cause for the infertility. If there is no reflux and it's bigger than 2.5, sometimes you just don't, you know, some veins reflux, others don't, and you just don't see it. I would flag that as possibly a problem, but that would need to be linked with your sperm analysis, your COMET test, your DNA fragmentation, you know, whatever one your andrologist has used. If, however, you've got great big veins and they reflux, again, in the presence of abnormal DNA fragmentation, I would have no question about treating that. That is a good going varicocele. And those individuals usually will have pain and will notice the swelling. But see, we are creatures of compromise and habit. And because of that, varicoceles, because they creep up so slowly over decades, most of the time we just think, oh, that's just, oh, it's just a thing. It's, you know, there's nothing wrong. I'm just not as fit. It's just a stitch. Whereas when you break a leg, it's an acute pain. You know something terrible has happened. You go and get it fixed. So we live with these things that creep up on us. And you know, they're all over the place. You know, you have a little mole and it grows slowly. Whereas if you've got a little black dot and within 2 weeks it's huge on your face, you think, oh, that must be a skin cancer. So we're primed to ignore things that change very slowly. And varicoceles change slowly. So we often ignore them and we just assume that they are part of our normal lives. And that's why a single test, an ultrasound, where irrelevant of what it looked like previously, you just do a spot check. Yep, the veins are big. Yes, they're refluxing. That is it. You've got a varicocele.
Okay. And in this scenario where doctors have decided that the varicocele needs treatment, what are the options available for guys out there?
2 ways. You either have an operation, and that was the gold standard, has been the gold standard for decades, probably the better part of 100 years. And the other is an embolization. And somebody has asked about risks, benefits, dangers, etc. The surgical option was always considered to be the one where you had as high a possibility of success, greater than 90%, whereas a varicocele embolization, which is the treatment through the vessels, and I'll explain it in a minute, was considered a lower to have lower chances of success and a higher chance of immediate success. So that means you do the treatment and still there's a bit of varicocele left, or was believed to have a higher chance of failure. So you couldn't find a vein, the vein to even treat it. Current figures, surgical, still the numbers are the same, over 90% success rate. Varicoceles, in the general interventional radiologist's hand, they quote 10 to 15% failure rate of a left varicocele and a 15 to 25% failure rate on a right. That's quite a high failure rate. And you can see why for years varicocele treatments by surgery were considered the better option. On the other hand, having an operation, you need an anesthetic, you need to have a cut just at the level of the groin, so just where your hip bends, and then they had to make that little cut there, find the veins, tie them off. An embolization is all done through a needle hole, getting into the blood vessel, working your way round into the varicocele vein or the gonadal vein, and then finding the main vein, blocking the main vein, and by doing so, treating it. And then there are nuances, other things that you can do. So in my situation, I don't just treat that main vein. And how do you treat it? Sorry, that's something I didn't mention. You treat it, whereas the surgery, they just tie them off, they ligate them. And then that's a very permanent, very effective treatment. With an embolization, you block the vein, and you can use certain types of coils. I use platinum coils. You can use glue. You can use a sclerosant, which is the equivalent of a medical paint stripper, irritates the vessel wall and blocks the vessel. Those are the three main options. You can also use various gel-like materials to plug the vein, but the main three are glue, sclerosant, and coils. Is one better than the other? In the right hands, all of them are very, very effective.
Sure. And you mentioned that there have been a question around any risks associated with embolization. Yeah, risks and any long-term effects, I guess.
Yeah, let's talk about those. So let's talk about the way I do the procedure and the risks that are involved. That's probably the most useful. I mean, I'm better talking about what I do than what others do. So when I do these, I do them all from the groin. Some people do them from the neck. What I've found over the last 25 years, well, actually within the first 3 to 5 that I did, is nobody likes having this done from the neck. It's very claustrophobic. You've got to put this great big sterile sheet over them, and you're working with a tube that's running over here, right next to their ear, and all this rustling, and and you have to have your head turned to the side for the whole time. You get neck ache. So I stopped doing it from the neck, and I do them all from the groin. So it's not a needle going directly into the testicle. You get into a blood vessel at the top of the leg. Clean that area, put some local anesthetic, stings like an insect bite for about 20 seconds, and then pass a tiny tube, and then using ultrasound and X-ray, get into whichever vessel, the left or right vessel. Inject some contrast medicine. What does that mean? A medicine that shows up on the X-ray screen, which allows me to see exactly what the vessel or vessels look like. Now, if there are more than one large vessel, then I get into each one of those and I block them at the level of where the vessels come together. So if you think of a tree trunk with the multiple roots, so that being sort of tree trunk with all the roots, you don't go down and treat all the roots. You block it at the level of the tree trunk. And in doing that, you deal with all of these vessels. But sometimes the main trunk also has side trunks going around the sides and working their way up. Now, if that's the case, then I get into each of those bigger side trunks and I block them with coils. Now, once I've done that main blockage here, I then check by injecting the contrast down that vessel to see if it goes downwards towards the testicle. The aim is for it to be blocked so that the contrast medicine does not go down. Once I have demonstrated that, I then put that sclerosant medicine above. So coils here, I put the medicine from here all the way up. And what that does is it irritates the vessel wall, spills into any small side branches, and it thromboses the whole vessel and the side branches. So what does that do? It means we use far fewer coils because any foreign body is there for life. Whereas the medicine, the sclerosant medicine, it does its work and then the body excretes it in minutes to hours. And so that's what the sclerosant does to block the main vessel, but also in treating the side branches, it means that the chances of recurrence are far lower. Otherwise, those side branches can start this whole process again and give you a recurrence of the varicocele. So because of that, I have found in doing it this way that the recurrence rate is less than 1% per year. It's very, very low. And the success rate from the way I do the procedure, and look, this is not, I've been doing it for 20 plus years. I've tweaked it for, the last 2+ decades, making tiny changes, using slightly different catheters, different tubes, different materials. And so because of that, the success rate in my hands for a left side, or the failure rate, which I was quoting, it's 0.5%. So 1 in 200 patients, I will not find the vein. And on the right side, it's 1%. So 1 in 100. And if that happens, I then arrange for the patient to have a special mapping scan. And that shows me all of the veins, everybody's veins everywhere within the abdomen and pelvis. Once I have that, even if you've got a vein which is in a very odd position, and sometimes these veins can be very strange. A right-sided varicocele can be draining to the left side of the body. It's just odd. So you map these veins, and then once you've done that mapping scan, I think I've failed about 3 times because the patient didn't have a vein that drained upwards. It all drained into the groin or such like. So after a mapping scan, it's almost unheard of to fail. So the success rates have improved hugely now with the interventional radiology option. The risks are lower because you're just making a needle hole in a blood vessel, which means after the procedure, you lie in bed for an hour, and then you're up and about after that hour, and a half an hour after that, you go home. And the only thing you need to be aware of is for the next 5 days, you don't do any heavy exertion. You can walk around and such like and do your normal day-to-day activities. But I don't know, if you're a kitchen fitter or a plumber, you can't be humping heavy weights. If you run a moving company, you can't be doing that for 5 days. If you have a desk job, take some paracetamol and get on with it if you wish, or you've got a good reason to take a day or 2 off to recuperate if you wish, but you won't affect the outcome.
Absolutely.
That's the whole procedure. Risks, because somebody asked the dangers of a varicocele embolization. Now, when you look online, there's a lot of scary things have happened. So you can put coils in the wrong place. So I get rid of that by doing that, injecting the contrast to look exactly at where the veins are. And so the coils don't even come off the shelf until I've done all of that. And then the coils can, so otherwise, that you can put them in odd vessels around the pelvis. You can damage the kidneys, and then the coils theoretically can move, and they can shoot off and block a kidney. You can lose a kidney because of that. They can shoot off into the lungs and cause blockage to lung blood vessels. You'll be pleased to know, however, that in 20 plus years, that's never happened. And it's not luck. It's because of the way we put the coils in, and then we put the medicine above, so that everything above the coils is treated. The coils are fixed into place lower down. The vessel is completely blocked, and the side branches are all blocked. And after those 5 days of you taking it easy, nothing's going anywhere. So that's the one risk that when you look online. The other risk that you will have seen online is damage to the testicles. Now, if you treat vessels too low, you compromise the blood flow leaving the testicle, and I will explain that in a minute. And that's why I don't treat all of these little ones. I treat the main trunk. And once I've blocked that, I put the medicine which blocks vessels above, so that medicine does not go down and damage the testicle. So the sclerosant, some people just put pressure at the level of the groin. So basically press from the outside of the body somewhere here, and inject the medicine up here. Now, a bit of pressing from the outside over here is, in my opinion, not fail safe. So some of that medicine can trickle around where you're pressing and go down and irritate the testicle. So the way I prevent that is by checking that the coils have blocked and putting the medicine above. So we've not had testicular damage. Now, the question that is often asked is, well, if you're blocking the vessels, the blood can be flowing in, but the blood can't drain out. So that's essentially killing the testicle. Well, the wonders of creation or evolution, depending on your bent, the testicle, around the testicle, within the scrotal sac, you've got the deep scrotal veins or the ball sac veins, and the blood reverts its flow pattern into those vessels. And that changeover is part of the reason why patients get some aching after the procedure, and that aching can last anything from no pain at all to aching for a couple of months. And I will say 1% of patients are left with a low-grade ache with a very good apparent result on ultrasound and all indices, so sperm analysis, but they're left with this low-grade ache, and we never find a reason. We don't know, we're not that clever. We don't claim to, I don't claim to be. I do a job. I do it as well as I can. And when it reaches a point where I don't know, first person to put my hands up and say, I don't know. I can't explain it. So that is, again, a small risk. 1% of patients will have some aching. Now, in the immediate aftermath, you can have a bit of bruising where the procedure is done from, a bit of bleeding from there. That's why we press on that area, and then we get you to stay in bed for an hour, just to allow that to settle. But you can be left with a bit of bruising. Well, is bruising a risk? It's like having a blood test. Infection, we do this in a sterile operating room. We've never had an infection. But I always tell patients, if the area where you have had that procedure done, if it becomes red or inflamed, go to your GP, have them check it. If they're worried about an infection, they'll give you some antibiotics. Those are the risks. The benefit, after that pain, which almost every patient gets for the first week or two, there's gradually a reduction. The swelling of the varicocele initially can get worse because, remember, we block the vessels, so there's further back pressure as the blood then is diverted into the deep scrotal veins. So you think, gracious, he's actually made it worse. And occasionally some of those big veins can clot off because they're redundant. And then when you examine yourself, you think, oh, it's much worse, it's much bigger. It's because the vein becomes hard because it's clotted. And if you think about the time it takes for a black eye to heal, it can take 4 to 6 weeks. Well, a varicocele vein which clots off, whereas there's a few microns in depth of blood which causes the black eye, it can be 4 or 5 millimeters. So that can take weeks, if not months, to gradually be absorbed. So those really are the risks involved and the limitations of having the procedure. Is it dangerous? In the wrong hands, anything can be dangerous. Most of the andrologists work with specific either surgeons who do this operation or interventional radiologists who specifically do this operation, this embolization. In those hands, the risks are very, very small. And I've told you the risk profile for my patients and the success rates. So, and it's not unique to me. I mean, I'm talking on behalf of my colleagues who I work with. All of us speak about how we do these procedures, and all of us are trying to advance this to make it accessible, to make it more available. And look, I know how difficult it is to get this done within the NHS, but I do these in the NHS. I have always done them in the NHS. It's just the weight of referrals are so huge. But it's not just a private procedure. It is done in the NHS, and most hospitals, certainly most hospitals that have interventional radiology, will be doing this to some degree.
Yeah, brilliant. That was a very informative answer. Thank you.
One other thing, the life cycle of sperm, 90 to 100 days. Don't expect improvements for the first 3 months, or expect improvements, but expect the best improvement after 3 months. So you will get that steady rise, in that steady improvement, and at about 3.5 months it'll start to plateau, but you'll have a continued improvement which will go on for anywhere up to 6-9 months, even up to a year, and then you will reach your new point of stability. But you don't go and have IVF or sperm harvesting, ICSI, whatever, or indeed a new analysis at the 2nd month when you know it's not yet as good as it could be. You're setting yourself up for suboptimal results, or a suboptimal pregnancy potentially. It's not to say that that will happen, but if time is not the major limiting factor, wait the 3 months.
Sure. And kind of at least 3 months from what you were saying there, I guess, is if it's going to continue potentially improving after that. You led on to what I was going to ask there. It leads on to I think a very valid question, is that if someone is azoospermic, would they be recommended a varicocele embolization or varicocele treatment, let's say, and why?
Now, that is a really interesting question, because there are so many reasons for that. Now, in most patients, what then happens is they have sperm harvesting. You want to get what is available. But if there is a varicocele, that sperm harvesting may yield damaged DNA'd sperm. So most andrologists who do sperm harvesting would want everything else optimized. And it's not just a varicocele. I mean, he or she would tell you that you need to stop smoking, you not have, cut out the alcohol, plenty of rest, reduce stress as far as is possible, get on those vitamins, make sure that the biome is not, by biome I mean swabs or cultures of you and your partner don't have dangerous bacteria that could compromise. There are so many factors, but most of them are really obvious. Most of them are about healthy living, and most of us want to live healthily, but we get into habits which perhaps are compromising that.
Brilliant, thank you. So yeah, I guess it's without further ado, we'll come on to the questions. Now, we had some pre-submitted questions, but I'm looking through them now, and I think you've answered each and every one of them in throughout your answers already in your dialogue. So thank you very much. That shows how informative it's been. Some have come in throughout our
So I
talk.
saw one coming in at the bottom. I picked up one or two of them, but not all of them. So I'm not sure if I've answered all of them.
So, for example, there's one which I don't think we've covered, but would a varicocele be having an impact on sperm production in men with Sertoli cell only syndrome?
I don't know. Honest truth, I don't know. It's something for me to look up, and Sean, I can get back to you.
Thank you.
Bring that question over to me. I'll do some research. So this is part of what I was saying. Look, if I don't know something, I'm not going to sort of talk rubbish. Let me see what I can find out.
That's amazing. Thank you. I'll follow up. I'll ping it over to you on email and feed it
And then
back.
you can share it with the on the group or with the individual concerned. I mean, okay, they're being sent anonymously, but perhaps if you give me a week, or whoever put that question in, if you come back to wherever these kind of questions are answered on this site, give me a week to 10 days. I need to find out from people who are cleverer than me, and I'll come back to you, Sean.
Thank you. Yeah, that particular question came through on the chat, so I know who sent it, so I can feed it back to them. That one's been covered. Are there any proven relationships to varicoceles and vascular diseases?
Not directly. Now, this is an interesting one, though, slightly off the beaten track. You can get abnormal vessels in certain connective tissue disorders, which cause dilation of various vessels. And there may be tenuous links there. But in those circumstances, the underlying connective tissue disease will more than mask chasing these. And even in those circumstances, because I have treated patients with such problems, it is not a contraindication to have the varicocele treated and thereby have improvements to the symptoms of the varicocele, as well as improvement to sperm analyses. So that's not a, it's a bit of a circuitous answer there.
Yeah.
But yes, connective tissue disorders can affect the heart and can affect these veins.
Thank you. And there's one more question. This one's from me. So I had a varicocele embolisation 6 years ago with metal coil. And as you mentioned, with a foreign body, it's there. It's always going to be there. Should I feel that? Should I be able, if for example, I'm lifting up my left leg almost, towards my body, should it be causing me any aggravation?
Not a chance.
Okay. And if it does, should I be worried?
It's something else. So the coils, if I were to hand you one, you would barely feel them. So they are not stiff platinum. It's almost like a piece of fine silk thread with some little filaments on them. You can barely feel them between your fingers. And they follow the contours of the vessel. The reason that they are so fine and floppy is so that they will just follow the contours of the vessel. Now, if you feel something, it is more likely that what you're feeling is the scar tissue of the vessel when it thrombosed and then the body scarred it, rather than the coil itself. And just to put it into perspective, all the coils that pretty much everyone uses now are platinum. There are no known allergies. And also, they are all MRI compatible. Yes. Certainly, a 1.5 Tesla MRI, it can be in the field. There isn't a problem. And by way of perspective, when you go and have your gallbladder or your appendix out, you get clips put inside you where they've done these operations. Those clips are there for life. Those are not usually platinum. So, and they, after 6 months, don't cause problems with having MRIs. So while we are quite correctly averse to the possibility of having a foreign body, if you have had an operation, you almost certainly have had some sort of foreign body. Certainly, if it was a laparoscopic operation, there are clips involved.
Yeah, sure. And actually, I went for an MRI a few years after having my embolisation. I had to get certificates
Yep.
from the operating hospital,
Yeah,
to enable me to have it. So, but yeah, it was all fine. But yeah, and I don't set off airport scanners, which
oh, and
I
the
was.
other thing, very frequently get asked. I mean, if you travel, you want to know that your coil is not going to cause problems. At the moment, they don't trigger anything. Who knows, with security getting more and more tight and sensitive, if they'll start picking these up. I think the opposite, though, will happen with security getting more clever, if you like, with AI bases. They will be able to, when an alarm goes and you go through that scanner, they'll be able to spot a legitimate medical foreign body. And I'm sure they will, in the not too distant future, have full atlases where the AI, if you like, system spots a hip and can even tell you the make, the model, the whole lot of what type of hip replacement it is. And the same probably will go as things get cleverer and cleverer to coil. So actually, I think in time these things are going to be less important. On the other hand, it'll be able to spot the make, the model of gun, the type of bullets that you're carrying, the whole lot.
And that's exactly what we want. So one last thing, Stephen, before we go, it says, it's just come in, not a question, but just a message of thanks. Stephen treated my varicocele in September following a referral from Jonathan Ramsey. We underwent our first round of IVF and it's ended in success, in brackets, baby due in August this year. The
I am
embolisation,
so pleased.
it's great to be able to feed that back, and it's hope is what keeps a lot of people going as well. I know for other people who aren't quite there yet, this type of story helps immensely.
This is the reason why I do what I do.
Amazing.
What a delight. Oh, that is such a thank you for sharing. Whoever did share that, thank you for sharing that. That warms my heart.
Amazing. Yeah, he says, the embolisation is something I fully believe is the reason for the success. And again, I cannot thank you enough for your help.
I will be the first to put my hand up and say it is not. It is one of a whole sequence of very effective interventions, from whatever happened with your partner, whatever Jonathan Ramsey did, whatever the dietitian, if you were involved, whatever vitamins you took. But I'm not taking it away from me. I contributed to this and I will sleep happier tonight. So thank you for sharing that.
It is, yeah, you did, Stephen, and I personally know and have spoken to so many other men that you've helped, and everyone is always grateful, and I know many must contact you, but yeah, trust me, there are so many people out there that are just so grateful for all of the time that you've been doing this, and because you know why people are doing this, they want that family, and yeah, so thank you for helping that along the way, and thank you for coming here this evening.
Delighted. Look forward to playing with you guys again soon, or having another one of these. It's always it puts into perspective sort of when I'm stuck in a dark room doing a procedure and it's getting tricky and I'm thinking, oh, why do I do this? But no, it's delightful to get feedback like that. So thank you for inviting me. It's a privilege. See it as a privilege.
Thank you. I'm going to try something new. So I'm going to say goodbye, but I'm not going to press end stream. I'm going to try the leave button and hopefully we'll go back to the backstage area. But if not, I will speak to you after. But thank you for coming, Stephen.
Not at all. Thank you. Thank you very much. And
thanks everyone for joining us as well.
Okay. Yeah.
Bye-bye.
Bye.